हेलो फ्रेंड्स, आज की इस वीडियो में हम एंटीरियर शोल्डर डिसलोकेशन के बारे में पढ़ने वाले हैं। एंटीरियर शोल्डर डिसलोकेशन क्या होता है? इट इज एन इंजरी इन विच हेड ऑफ ह्यूमरस कम आउट ऑफ ग्लिनोइड कैविटी एंड लाइज एंटीरियरली. If this is the head of the humerus and this is the glenoid cavity, तो ये जो head of humerus है it will come anteriorly and lie over here. शोल्डर जॉइंट जो है ह्यूमन बॉडी में कॉमनेस्ट जॉइंट है विच मोस्ट कॉमनली डिसलोकेट, क्योंकि उसकी एनाटमी ही ऐसी है कि इट इज मोर प्रोन टू डिसलोकेट. और जो डिसलोकेशन है शोल्डर जॉइंट में डिसलोकेशन है, इट इज बेसिकली ऑफ टू टाइप्स, इंटीरियर डिसलोकेशन एंड पोस्टीरियर डिसलोकेशन, out of which anterior dislocation is much more common, that is 95% than the posterior dislocation. Now we will see the mechanism of injury which leads to anterior shoulder dislocation. It may be an indirect force. Indirect force means if a person falls on an outstretched hand with shoulder abducted and externally rotated. Shoulder abducted and externally rotated इस position पे अगर कोई person गिरता है then it causes anterior shoulder dislocation. सेकेंड इज द डायरेक्ट फोर्स. अगर कोई डायरेक्ट ब्लो पड़ रहा है, फोर्स लग रहा है फ्रॉम पोस्टीरियर एस्पेक्ट ऑफ शोल्डर, देन इट विल डायरेक्टली कॉज द एंटीरियर डिसलोकेशन ऑफ द शोल्डर. Now we will see the classification of the anterior dislocation of the shoulder joint. Anterior dislocation of shoulder joint में क्या होता है कि जो head of humerus है, it comes out of the glenoid cavity and lies anteriorly. So, depending upon the position of the dislocated head, it may be subdivided into three types: preglenoid, subcoracoid, and subclavicular. First is the preglenoid type. Preglenoid type, if the head lies in front of the glenoid, ये this is the glenoid cavity. अगर head lies in front of the glenoid cavity, then it comes under preglenoid type. Second is the subcoracoid. If the head lies below the coracoid process, this is the coracoid process. If head lies below the coracoid process, then it comes under subcoracoid type, and it is the most common type. And next is the subclavicular type. If the head lies below the clavicle, this is the clavicle, and if head lies below the clavicle, then it comes under subclavicular type. See the pathological changes that occurs in anterior dislocation of shoulder joint. जब भी shoulder joint में anterior dislocation होता है तो क्या क्या most common pathological changes मिलते हैं हम. This is the normal transverse section of the shoulder joint in which this circular part is the head of the humerus, and this is the glenoid, and this is the posterior capsule, and this is the anterior capsule and labrum, and this is the periosteum, and this is the subscapular tendon. So in this diagram, this is the anterior position and this is the posterior position. So our head is going in this direction. First is the Bankard lesion. Bankard lesion में क्या होता है कि जब भी जो head of humerus है anteriorly dislocate करेगा, there it will cause stripping of glenoidal labrum along with the periosteum from anterior inferior surface. As a result, what will happen? ये जो head of humerus है that will come in front of scapular neck in the pouch thereby created. You can see this pouch जो कि बना है, तो ये हेड ऑफ ह्यूमरस इनके सामने आ जाएगा. So this is the Bankard lesion. In severe injuries, what happens? It may also cause avulsion of bone piece from anterior inferior glenoid rim. This is called as bony Bankard lesion. Next is the heel shack lesion. There is a depression on the humeral head. You can see this depression in the posterior lateral quadrant of the humeral head. क्यों होता है? It is because of the impingement of anterior edge of the glenoid on the head as it dislocates. जैसे ही head dislocate होता है तो ये जो एंटीरियर एज ऑफ ग्लिनॉइड है दैट विल कॉजेस इम्पिंचमेंट ऑन द हेड ऑफ द ह्यूमरस एंड लीडिंग इनटू अ डिप्रेशन ऑन द ह्यूमरल हेड। तो ये जो डिप्रेशन कॉज हुआ है इसी को ही हम हिल शैक लीजन कहते हैं। थर्ड इज द राउंडिंग ऑफ anterior glenoid rim occurs mostly in chronic cases जिसमें head of ह्यूमरस जो है डिसलोकेट होता है रैपिडली ओवर इट, क्योंकि बार बार डिसलोकेट हो रहा है इसलिए वहां पे घिसावट आ जाती है और वो राउंड ऑफ हो जाता है। फोर्थ pathological changes that we can see is the associated injuries like fracture of greater tuberosity, rotator cuff tear and chondral damage. Now coming to the diagnosis, first is the presenting complaint. पेशेंट कम्स विद अ सीवियर पेन। जब भी पेशेंट कैजुअलिटी में आएगा देन हिज शोल्डर विल बी इन abducted and externally rotated position or elbow is supported with the opposite hand. Adduction is strictly restricted or and there is a history of fall on an outstretched hand. On examination, patient patient keeps his arm abducted. Patient हमेशा अपने हाथ को abducted position पे ही रहेगा. The normal contour of the shoulder joint is lost and it becomes flattened. On careful inspection, one may notice the fullness below the clavicle. जो normal contour है shoulder joint है वो lost है एंड इट बिकम्स द फ्लैटेंड, राउंड की जगह फ्लैटेंड दिखता है। जो देयर इज अ फुलनेस बिलो द क्लेविकल, क्यों? क्योंकि जो हेड ऑफ द ह्यूमरस है वो क्लेविकल के नीचे आ गया, इसलिए देयर इज अ फुलनेस बिलो द कैविकल एंड दिस कैन बी फेल्ट बाय रोटेटिंग द आर्म। जब आप आर्म को रोटेट करोगे तो दिस कैन बी फेल्ट। What are the associated signs related to the anterior dislocation? First is the Dugas test. Dugas test में क्या होता है? There is inability to touch the opposite shoulder. जब आप पेशेंट को बोलोगे कि आप अपने अपोजिट शोल्डर को टच करो तो जो पेशेंट का अफेक्टेड हैंड है वो अपने अफेक्टेड हैंड से नॉर्मल शोल्डर को टच नहीं कर पाएगा। सेकेंड इज द हैमिल्टन रूलर टेस्ट। हैमिल्टन रूलर टेस्ट में क्या होता है? बिकॉज देर इज अ फ्लैटनिंग ऑफ शोल्डर इट इज पॉसिबल टू प्लेस अ रूलर ऑन द लैटरल साइड ऑफ द आर्म, क्योंकि जो नॉर्मल कॉन्टूर ऑफ शोल्डर है वो लॉस हो गया है और देर इज अ फ्लैटनिंग। इसकी वजह से जब आप स्केल को रूलर को लैटरल साइड ऑफ आर्म में रखोगे देन दिस टचेस द acromion and lateral condyle of the humerus simultaneously, which is a sign of anterior dislocation. Diagnosis is easily confirmed on an X-ray of a shoulder joint, जिसमें से most commonly X-ray होता है AP, anterior posterior view of shoulder joint. This is an anterior posterior X-ray of a shoulder joint clearly showing the anterior dislocation of the shoulder joint. In you can see this is the head of humerus lying in front of the glenoid cavity which is normally held here. This is an X-ray showing the Bankart lesion. This is the bony Bankart lesion and here is the depression in the humeral head which is an Hill-Shack lesion. When you take a transthoracic lateral X-ray, you can see the C-shaped rolling line. You can here see this C-shaped rolling line. This is also an finding of X-ray where you can distinguish whether it is an anterior dislocation or not. Other investigations which are commonly done to confirm the anterior dislocation of shoulder, first is the arthrography. Arthrography is more helpful to evaluate the rotator cuff tear due to previous dislocation. Next is the CT scan. In CT scan helps to detect the defect in the head more accurately. Whereas talking about the MRI, MRI is very useful to evaluate both the soft tissues in addition to bony injury. Treatment of an acute dislocation is by reduction under the sedation or general anesthesia, followed by immobilization of shoulder in a chest arm bandage for 3 weeks. After the bandage is removed, the shoulder exercises are started. Mix of reductions. Basically, there are two types of reduction. First is the close reduction, second is the open reduction. In close reduction, there are three methods. First is the Hippocrates method, second is the Stimson's gravity method, and third is the Kocher's method. Hippocrates method, this is the diagram of an Hippocrates method, and it is an outdated method in which the reduction is done with the help of foot in the axilla. Stimson's gravity method, in this is the diagram showing the Stimson's gravity method. In this, patient is in a prone position with a weight attached to it. Weight is attached over here and the patient is in prone position, and gravity helps in the reduction as the hand is hanging downwards, so that the gravity will help in the reduction. Next is the Kocher's method, and this is the diagram of the Kocher method, and this is most effective and most commonly followed method. Open reduction is indicated when close reduction fails, soft tissue interposition is there, greater tuberosity fracture is there, displays more than 1 centimeter after reduction, and large glenoidal rim fracture. Early complication includes injury to axillary nerve, resulting in the paralysis of the deltoid muscle with a small area of anesthesia over the lateral aspect of the shoulder, which is also known as regiment band sign. Can be confirmed by asking the patient to try to abduct the shoulder. Though the shoulder abduction may not be possible because of the pain, one can feel the absence of contraction of the deltoid. Here the treatment is conservative and the prognosis is almost good. Late complication is the recurrent dislocation, and second is the traumatic osteoarthritis. So recurrent dislocation. Shoulder joint is the commonest joint to undergo the recurrent dislocation. This results in the following. This is because of the following cause, as it is an anatomically unstable joint. Example, as in Marfan syndrome. It may be There may be an inadequate healing after the first dislocation, or as in case of an epileptic patient. Second is there may be a traumatic osteoarthritis after the dislocation of the joint. So this was all about the anterior dislocation of the shoulder joint. अगर आपको वीडियो अच्छी लगती है तो वीडियो को लाइक करें, प्लीज़ मेरे चैनल को सब्सक्राइब करें, अपने फ्रेंड्स के साथ शेयर करें, एंड थैंक्स फॉर वॉचिंग इट.